Hey everyone, this is Anthony Chan, and I'm thrilled to welcome you to my channel. Today we're diving deep into the fascinating world of hepatocellular carcinoma HCC, with a special focus on its unique vascular features. Let's get started. Angiogenesis is one of the fundamental hallmarks of cancer. Since HCC is a highly vascularized tumor, angiogenesis plays a particularly crucial role. Histologically, angiogenesis in HCC is evidenced by the presence of unpaired arteries and sinusoidal capillarization. These pathological features not only enhance our understanding of HCC, but also have significant clinical implications. Let's discuss unpaired arteries. In normal liver tissue, arteries are usually found alongside bile ducts and portal veins, forming portal triads. However, in the case of HCC, we observe the presence of isolated arteries without these accompanying structures, leading to the term unpaired arteries. This is an unpaired artery in a well-differentiated HCC. This is another example of an unpaired artery within an HCC. Here are the pathological characteristics of dysplastic nodules, early HCC, and progressed HCC. We will explore the precursors of HCC in more detail in a subsequent video. Unpaired arteries are a distinguishing feature of HCC progression. They first appear in high-grade dysplastic nodules, and their prevalence increases as the lesion advances to early HCC and subsequently to progressed HCC. Simultaneously, the number of portal tracts diminishes. There is a transition in blood supply from portal venous to arterial. Indeed, research has indicated that the number of unpaired arteries is associated with the tumor grade. Clinically, the presence of unpaired arteries is crucial for imaging diagnosis. They contribute to the characteristic arterial phase hyperenhancement we see on CT and MRI scans. This hypervascularity is often the first sign that alerts radiologists to the presence of HCC, especially in cirrhotic livers. Here is a classic example of HCC as demonstrated on multiphase CT, characterized by arterial phase hyperenhancement followed by rapid washout in the portal venous and delayed phases. Furthermore, arterialization of the blood supply of HCC provides the basis for transarterial chemombolization, TACE. Now, let's move on to sinusoidal capillarization. In normal liver, sinusoids are specialized blood vessels with fenestrated endothelium, allowing for efficient exchange between blood and hepatocytes. However, in HCC, these sinusoids undergo a process called capillarization. This involves the sinusoidal endothelial cells losing their fenestrations and forming a basement membrane, transforming them to resemble the typical capillaries seen elsewhere in the body. As for the unpaired arteries, the degree of sinusoidal capillarization increases gradually during multi-step progression from cirrhotic nodule through dysplastic nodule to HCC. Normal sinusoidal endothelial cells, except those in periportal or periseptal regions, are typically negative for CD34. In HCC, the sinusoidal endothelial cells begin to express CD34. This is illustrated by an example of HCC where the sinusoid CD34 positive, in contrast to the CD34 negative sinusoids found in non-tumorous liver tissue. Here's another example of HCC on the right, displaying CD34 positive sinusoids as opposed to the CD34 negative sinusoids in the non-tumorous liver tissue on the left. A complete sinusoidal capillarization pattern, characterized by diffuse and strong staining of CD34 in the sinusoids, is observed in the majority of HCC cases. CD34, which is commonly available in most labs, is an effective marker for HCC, boasting an 88% sensitivity and 96% specificity. However, it's worth noting that a minor fraction of other liver lesions, specifically about 3% of focal nodular hyperplasias, 21% of hepatocellular adenomas, and 4% of high-grade dysplastic nodules also demonstrate complete sinusoidal capillarization with CD34 staining. We'll be discussing this diagnostic marker for HCC in greater depth in an upcoming video. Microvessels in HCC undergoing sinusoidal capillarization exhibit two distinct types: capillary-like microvessels, characterized by small, scattered capillaries with no or narrow lumen, and sinusoid-like microvessels, which have a wide and prominent lumen structure. An alternative term for this vascular pattern is vessels that encapsulate tumor clusters, VETC. The prevalence of VETC positivity in HCC varies widely across studies due to differences in study populations and definitions. There isn't a standardized cutoff percentage for the tumor area showing the VETC pattern. In studies involving cohorts that underwent curative resection, the prevalence of VETC-positive HCCs typically ranges from 14% to 56%, with most findings falling between 30% and 40%. Although the term VETC was first introduced in 2015, the concept of tumor nests surrounded by blood vessels, or sinusoidal tumor angiogenesis, was initially described in 2004. In most studies, the VETC pattern is defined as a continuous lining of sinusoid-like vessels that isolate and encapsulate individual tumor clusters, forming a cobweb-like pattern. VETC formation heavily depends on angiopoietin 2. Unlike the conventional EMT pathway for metastases, VETC-positive HCCs can spread through an invasion-independent process by embolizing tumor clusters. VETC positivity is associated with more aggressive tumor behavior, a larger tumor burden, a higher tumor grade, and a worse prognosis. In the video description, you'll find a link to a comprehensive and open-access review of VETC and HCC. In conclusion, unpaired arteries and sinusoidal capillarization are key features of HCC vasculature. They play a crucial role in the diagnosis, prognosis, and treatment of this challenging cancer. Thanks for watching. If you found the content helpful, please subscribe to the channel and leave your comments or questions. Your feedback is invaluable and helps me improve future content. Thank you for your support.